Good evening, everyone. Thanks so much for attending this webinar put on by the cardiovascular team of the Minnesota chapter of the American College of Cardiology. My name is Stewart, clinical pharmacist and clinical lipid specialist, and it is my absolute privilege to have the opportunity to present to you on a topic that I am so passionate about, and that is the role of the pharmacist in serving cardiology. And so I am very excited to highlight the works of pharmacists, the medication superhero. Many of you may recognize this gentleman here. This is Dr. Mayank Amin, the superhero pharmacist who's known for administering countless number of COVID-19 vaccinations to his communities in Pennsylvania. Dr. Amin started his own pharmacy when the local pharmacy serving his community closed down. And so Dr. Amin is just one example of a pharmacist doing superhero things. What I'd like to talk about for the remainder of this brief presentation are some potential roles for the clinical pharmacist in a cardiology setting. Now, these roles are not necessarily unique to cardiology. Many of these roles are roles that are being performed by pharmacists across the country in many different settings. In Minnesota, we actually have a very robust pharmacy presence in primary care. That's where I spent the majority of my career at Park Nicollet, working alongside internal medicine clinicians as part of a very busy primary care practice. So these potential roles are leveraging provider time, providing remote patient services, improving patient access, some scholarly activities, and some specialty services as well. So I'll start off by discussing leveraging provider time. And so, in this particular role, a pharmacist would see patients directly in clinic in collaboration, with a healthcare provider, whether that provider is a cardiologist, advanced practice practitioner, et cetera, and it could be in primary care or cardiology. And so typically this involves a pharmacist seeing a patient at the same time that they are seeing their healthcare provider. And in this particular role, the pharmacist would see the patient first for perhaps 10 or 15 minutes, get an adequate, extensive, thorough medication history, do a quick personal family history, perform a 10-year ASCVD risk assessment, and really identifying ways in which pharmacotherapy could be optimized. And now this could include, depending on the setting, non-cardiovascular related medications as well, which is what I focused on mostly within primary care. But of course, in a cardiology setting, that would be more cardiovascular focused. So it could be opportunities to add a PCSK9 inhibitor, add a GLP-1 receptor agonist or an SGLT2 inhibitor for a patient with diabetes. It could be optimizing their statin, et cetera. And finally, identifying labs that could be made to assess medication safety and efficacy, as well as perhaps placing referrals for other places the patient could go within their healthcare system to address other needs that couldn't necessarily be dealt with at the present time. The second role is the remote patient services. So in this role, this is typically done either by telephone or now, with the ramp up of telehealth virtually. And so after seeing the patient before the provider, then you would have a conversation with that provider on optimizing pharmacotherapy and decide what things could be prescribed today. And then from there, I would follow up with the patient to assess for the tolerability of that medication, titrate to effective doses, troubleshoot any new or emerging cost concerns, as well as remind the patient if labs need to be drawn, again, to check for that efficacy and safety piece of the medication. Where this would potentially apply to cardiology is sort of two ways, and there can be more. Number one is tolerability of the medication. So this could be in the setting of a patient that has a history of statin-associated muscle symptoms. It could also be a patient started on a GLP-1 receptor agonist or an SGLT2 inhibitor. Titration to effective doses could be applied to, again, a GLP-1 receptor agonist, as they typically need to be titrated up to an effective dose based on how the hemoglobin A1C responds. Cost concerns is becoming a much more important issue to the field of cardiology, just with the PCSK9 inhibitors, because they were such an expensive medication. There were a lot of barriers with respect to insurance coverage and cost, which impacted the patient's ability to afford and ultimately take those medications. And medications, of course, don't work if the patient can't take them. And so this could be by way of copay cards, patient assistance programs where applicable, participating in the prior authorization process, et cetera. And of course, lab reminders to, again, determine whether your new statin or a different dose of statin or your PCSK9 inhibitor or your GLP-1 receptor agonist, SGLT2 inhibitor, or RND doing what they're supposed to be doing for the patient. In another area of this, it would be a consult service. So this could be, initiating and monitoring pharmacotherapies for smoking cessation, either initiating or optimizing medications for hypertension, as well as remote hypertension monitoring using a home blood pressure monitor, or in some cases, 24-hour ambulatory blood pressure monitoring. Diabetes, I already mentioned. And this could be, again, not just, I guess, starts of GLP-1s and SGLT2s, but potentially a patient may be on other diabetes pharmacotherapy, such as insulin, which, you may not want to or feel comfortable managing. And so a pharmacist is well suited to adjust the dose of insulin as needed and continue to manage those medications as best meets the needs of the patient and how they respond. With heart failure is now becoming more complex. Just maybe earlier, maybe within a month, the Canadian Cardiovascular Society published new guidelines for heart failure with reduced ejection fraction, where they're recommending now concomitant initial therapy with 4 different classes of medications: a beta blocker, sacubitril valsartan, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor. And so there's a lot of new medications to try to fit into somebody's life, especially when there's other medications that the patient may be taking for other things, all of which have to kind of play in the sandbox together. So patients will need help and empowerment and how to manage all that. And finally, the complex polypharmacy patient. Obviously, all of these things don't exist in a vacuum. There could be instances where patients are on 15, 20 different medications, which all need to get kind of sorted out in order for the patient to get the most out of all of those. And there's ways in which potentially the medications can be economized. Maybe they don't need to be on so many, and the pharmacist can kind of bridge that with the other prescribers of those medications to find something that works best for everybody. Improving patient access, I think, is a really important role for a pharmacist to play. This includes improving patient access to the system. So having that ability to follow up via telehealth, virtual monitoring between clinic visits, and having that communication point if there's medication questions, so that there's a fixed point that those questions can go to in order to get appropriately addressed and changes implemented. And then I've talked about it already, but improving patient access to medications. And those cost barriers are a challenge. And over the next 5 to 10 years, as the innovation train continues to move down the track, there are going to be more and more novel medications that are associated with potentially a high cost. But in addition to those high cost medications, I think that it's also important to increase patient awareness of the medication's role in treating their conditions, so that they can understand what that medication is doing for them, and it's doing, again, what it's supposed to be doing. Pharmacists also participate in a lot of scholarly activities, whether it's teaching students, educating other practitioners that they work with, participating in quality improvement initiatives, and also participating in research as well. And then a few selective targeted services that I've kind of pulled out of the literature would be a PCSK9 inhibitor clinic. Many pharmacists have worked alongside a physician assistant or a nurse practitioner to initiate the PCSK9 inhibitor and again, navigate that cost piece, as well as the longitudinal monitoring. There are several antiarrhythmic medication monitoring clinics that have been established, for those medications that have a ton of drug-drug interactions or require a lot of monitoring, such as amiodarone or dofetilide. And there even is, I've heard of a CV medication 101 service within a cardiac rehab, where patients, who are perhaps newly discharged after a myocardial infarction with a bunch of new medications, that get an opportunity to sit down with a medication expert and get all their questions answered about what these drugs are doing, why am I taking them, how long do I have to take them, et cetera. And so within the last just couple of minutes, I just want to highlight just a piece that was published a couple of years ago, a leadership perspective by Dr. Richard Kovacs in the Journal of the American College of Cardiology, in conjunction with two prominent pharmacists within the organization. And that Dr. Kovacs highlighted that cardiology is a field dealing with pharmacokinetics and pharmacodynamics of multiple drugs in complex patients over long periods of time. There's constant innovation, which requires implementation, and there are finite resources, and there's the ask of optimizing benefits of lots of different classes of drugs based on the best science. And the patients struggle to comply with these regimens, and sometimes it's just simply afford their medications. And I think all of these things can be assisted by the inclusion of a pharmacist. So finally, integrating a pharmacist within cardiology practices is endorsed by major national organizations, including the American College of Cardiology, American Heart Association, Heart Failure Society of America. And no matter where you go in the literature, you're going to find that pharmacist services are associated with improved outcomes, from improved adherence, improved surrogate markers such as LDL cholesterol, blood pressure, hemoglobin A1C, as well as clinical outcomes as well. I came across a paper not too long ago with a pharmacist-led hypertension service, where it was associated with reductions in stroke and myocardial infarction as well. So with that, I just want to thank, again, the organizers for the invitation to speak to you. If you are at all interested in what a pharmacist can do for you, please feel free to reach out to me or reach out to your local pharmacy department within your health system. And we'd love to engage in a conversation. Thank you so very much.